I, Dr. Achla Ingle, third year MD resident, I welcome you to my study tutorial. Today I will be discussing hypertension and new guidelines and some critical challenges we all face while prescribing medications. We all have patients with multiple comorbidities and we shall prescribe them accordingly. So without wasting much of time, sit tight and enjoy the session. Hypertension, we need a 24-hour ambulatory BP that should be more than equal to 130/80 according to the ESH guidelines 2018. The daytime mean should be more than equal to 135/85 and the nighttime mean should be more than equal to 120/70. That is according to the guidelines and to be said as a hypertension. Even if the BP is 130 to 139 or 85 to 89, then the patient needs treatment. But it should be the 24 ambulatory BP that should be done. Like if it is only once, then we need to call the patient again or tell him that he needs to calculate the BP and then come to you. So there could be a white coat hypertension, that could be a mass hypertension. That means the patient has hypertension just by having certain stressful situations like that of he may be afraid of the doctors, and um, the patient should have a 24-hour ambulatory BP monitoring. So we are aware that there is a nocturnal dipping. That means at the night time we have a BP should is lesser than that of the BP which is calculated at the daytime, and which increases the cardiovascular mortality. So whenever there is patient is a hypertensive, then there is decrease in the nocturnal or there is absence of the nocturnal dipping, and that will lead to increase in cardiovascular mortality. And overall, whenever the patient has hypertension, there is of course increased risk of cardiovascular mortality. So causes for hypertension, it could be a primary or a secondary. Secondary, coming to the causes, so we have renal. The most important is the renin-angiotensin activating system, which is related to that of the hypertension. So we need to perform renal Doppler in such patients, and it could be a young patient who is having uh, TMA like features, right? And the renal parenchymal disease, that is chronic glomerulonephritis, that could also lead to that of renal injury and renal injury causing hypertension. So there is this endocrine disorders which includes Cushing's, or we have Crohn's or hyperthyroidism or hyper increasing there is primary hyperparathyroidism and pheochromocytoma. So accordingly we can calculate VMA and we can or the urinary metanephrine levels, and we can prescribe the patient, and we can know if the patient has a certain hypertension, headache, palpitation like features. And we know that there is a, if the patient has an OSA component, that means there is a obstructive sleep apnea, so that will lead to that of pressure to the lung, and that in turn to the pulmonary veins, and that could lead to pulmonary hypertension also. The most common cause of secondary hypertension in children, which is more than that of less than that of 12 years, is renal parenchymal disease, and like that of glomerulonephritis. And in the adolescents, it is again renal parenchymal disease. Adults, it is renal parenchymal disease, and middle age we have Cons. Cons syndrome. Elderly, atherosclerosis is the most important factor. Now, if the BP, if a male patient comes to you and then his BP is say 160/100, so the first step is 24-hour BP monitoring, not straight away adding the medications. Now, in India, we straight away add medication because there is a certain issue with the compliance, and the patient may not be compliant, or if he is advised for the next visit, he won't be showing up. So that's why we start him on the antihypertensives. But the correct step is adding 24-hour ambulatory BP monitoring to his prescription. Then we need to see for the target organ damage like that of the nephropathy, retinopathy. And yes, we prescribe them the KFT, we prescribe them the UHG, ultrasonography, and TFT reports for knowing the cause, and PTH if available, then serum electrolytes, of course the fundus examination to be done, and 2D echo. So we have a Keith-Weger-Barker classification. This is a classification which tells us about the retinopathy. Now the first grading, it has graded the retinopathy into four types. The first grade is the mild. There will be retinal arterial narrowing, that is silver lining. It will look like a silver lining, and then there is this second grade, which is a definite focal narrowing and arteriovenous nipping. Then there could be flame shaped hemorrhages and exudates and cottonwood spots in the grade 3. Severe grade 3 retinopathy with that of the papilledema says it is a grade 4 pattern. Now, we are really reluctant to use these words as hypertension, urgency, and emergency. Let's look what is it. Emergency E4E, we have an end organ damage in it. So the BP should be more than that of 180 by 120 with the target organ damage. Now, if we're considering there's a hypertension urgency, then the BP should be more than equal to 180 by 120 without the target organ damage, and the patient obviously requires an hotel therapy. For the accelerated hypertension, the new onset changes in the fundus, we need to look at that. And then with hypertension emergency, that is an end organ damage which is present, that is considered to be accelerated hypertension. If we're talking about a malignant hypertension, that means the patient has an accelerated hypertension with that of papilledema. And resistant hypertension means the patient has already prescribed on that of antihypertensives, 3 antihypertensive, out of which one is a diuretic, that is considered to be a resistant, and we will see what is the treatment of the choice for the resistant hypertension. So the API guidelines say the first time if the patient has come with you with an hypertension emergency, then it is to be diagnosed as an hypertension. If the second visit we have a BP of 180 by 110 or BP of 140 by 90 with a target organ damage, then it has to be considered as an hypertension. And a third visit, if it is a BP is of 160 by 100, then it has to be considered as a hypertension. So with the first visit, I shall be repeating it. For the first BP, if the patient has a target organ damage, then it has to be in hypertension. If some people are not aware, and then the albumin comes as 3 plus, and there is actually bilateral raised cortical echogenicity in the UAG report. Then if the second time BP is say 180, and he should be in hypertension, or if the patient has a BP of 140 and there is a target, he should be called as an hypertensive. The third time the patient has even the 160 BP, then it has to be an hypertensive, right? For the target organ damage, microalbuminuria is very important. That means 30 to 300 milligram, it should be the albumin which is present in the urine, and 24-hour urinary creat to be done. So there is this arterial aging. So we have a cushioning effect. The normal individuals and the young individuals, they do not have atherosclerosis much of it. So there will be whenever there is increase in the blood pressure, then the pressure around the vessels would be taken up by the vessels itself, and there will be like a cushion, they will be absorbing it. But this doesn't happen in an atherosclerosis vessels. So this is causing increase in the pulse wave velocity. So if a young patient, there is a blood which is pumped and then it circulates, there is a pulse wave which is generated, which the vascular walls absorb those pulse, and there is a cushioning effect. And with the aging, there is stiffness of the vessels, there is no absorption of the pulse waves, and there is increase in the velocity of the pulse wave, which is causing increase in the pulse wave velocity. So aging of the arteries is not proportional to the age of the patient. Remember this. The best marker for hypertension is the pulse wave velocity. Very important as a marker for arterial aging. So we look into the central vessels. So we measure a central aortic pulse wave velocity. So this central vessels have high elastin and peripheral vessels have high collagen. And whenever there is increase in the arterial stiffness, that will lead to vasospasm. There is increase in the oxygen demand, there is increase in the afterload, there is decrease in the coronary perfusion, and there is increase in the LVH. So this is seen as an ECG. We say if the patient has an LVH, that means he has a hypertension. There is certain changes which have been occurred in the past, so it is a chronic hypertension. So the beta blockers increases the central pulse wave velocity. AC inhibitors, ARBs, they decrease the pulse wave velocity, and nitrates, they decrease the pulse wave velocity. So beta blockers are certain which is not to be prescribed, and yes, beta blockers are not prescribed usually, only when the patient has certain systolic failure or the patient has a coronary artery disease, then only we have the blood pressure which is then only beta blockers are prescribed. Coming to the management, there is a DASH plan. We have all heard it of it. So the salt intake should be less than that of the 5 gram, and there should be the red meat intake should be lowered down, and of course the saturated fat should not be consumed much. Then the fruits, vegetables, and nuts that should be consumed. Limit the alcohol, weight loss, and exercise for 30 minutes. Then coming to the drugs, for the drugs, there is of course a combination therapy. Never a monotherapy is prescribed. Okay, so starting from the A, C, and D. So these are the three things that we are familiar at this position. A is for the AC inhibitors or the ARBs. C is for the calcium channel blockers, and D is for diuretics. B for beta blockers. So if it is an uncomplicated hypertension, okay, is this simply a hypertension patient of 150 by 100 or 160 by 100 coming to you, we use A plus C or we use A plus D. So mostly we are giving telmisartan. Along with that we have amlodipine, calcium channel blocker. If it is not controlled, then we need to add A plus C plus D. Even though the patient is not controlled, the blood pressure is not controlled, then it becomes a resistant hypertension, and for that we have spironolactone. Okay, and look for the secondary causes for it. So spironolactone, eplerenone, or we have the prazosin. Prazosin could be prescribed as 2.5 or 5 depending upon the blood pressure. And we have beta blockers. So this beta blockers, these are only prescribed in case of heart failure or in case of arrhythmia or in case of a coronary artery disease. So in that we prescribe A plus B, right, or we have A plus C. If there is no response, then we need to add 3 of it, A plus B plus C. If there is no response, then we need to add diuretics. Even though the patient has no response, then it is a resistant hypertension, then we add to spironolactone. In case of hypertension along with the CKD, same regimen goes with the normal individual as with the normal individual, A plus C plus D in response if there is no response with A and C or A plus D. Mostly in CKD we give nifedipine, 20 mg or 10 mg, okay, 20 mg or 10 mg, BD, TDS depending upon the patient's factors. If the hypertension is there with the systolic blood heart failure, then we need to give A plus B plus D. So this regimen, and this is an exception. Okay, in coronary artery disease, A plus C, B plus C, and in case of systolic heart failure, A plus B plus D. Target BP should be 120 to 130 and 70 to 79, but in CKD patients we can accept to 130 to 140 and 70 to 79. Now, with coming to the low diastolic pressure, now we are lowering the systolic pressure. Okay, fine. But lowering of the diastolic pressure, is it good? No, because diastolic pressure would be resembling that of the coronary perfusion. Now, if the coronary perfusion is, if the diastolic blood pressure is decreased, the coronary perfusion will also be decreased. So, this is the aorta. Through the aorta, whatever blood is passing on, okay, so that is because of the diastole. In the diastole, the blood is coming from the atrium and then it is flowing back. Now, if the diastole blood pressure is decreased, then of course there won't be any of the outflow, and there is no outflow. That means the coronary perfusion is not there. So, hypertensive crisis. Coming to the complications of it: hypertension emergency, urgency, accelerated hypertension, malignant hypertension. So the BP is 120, 180 by 120. What is the rate of rise of BP? What is the rapidity, the length of time, the degree of target organ damage? This is all important to answer. So coming to hypertension emergency, that means there is an end organ damage with that of, there is a BP of 180 by 120. So there is the acute pulmonary edema. The patient may come as an acute LVF, left ventricular failure, or it can maybe as an encephalopathy. Then there could be a malignant hypertension, which is thrombotic microangiopathy. A patient may come as a preeclampsia or HELP syndrome, or an acute aortic dissection. These are 5 manifestations with that of emergency. So the drugs which are used in emergency, that could be a labetalol simply, as in case of preeclampsia, in case of the even the press, in case of any aortic dissection we use esmolol. Okay, but the beta blockers are used, and it could be a nicardipine or clevidipine, and we have phenoldiazepam or sodium nitroprusside. Coming to the acute pulmonary edema, in acute pulmonary edema, NTG or drip could be applied. Now, if it is an nitroglycerine, it is best for the heart failure as well. It is best for lowering of the hypertension as well. Okay, and in case of the angina also. So, it is best. So, 5 microgram per minute to 25 microgram per minute, we can help the patient with that. Or sodium nitroprusside could be used. Hypertension, encephalopathy or malignant hypertension or HELP, or in case of renal failure, labetalol or nicardipine could be used. In case of acute aortic dissection, it is the esmolol which is working along with the nitroprusside or NDG with that of the nicardipine. Yes, and here the patient has to be helped with reducing the BP drastically to 120 mmHg. Okay, so the ACD drugs, we have diuretics, thiazides, which are causing vasodilatation. There is chlorthalidone, we have hydrochlorothiazide. Now these causes much of the side effects, including hyponatremia, hyperglycemia, hyperkalemia, hyperuricemia, erectile dysfunction. So only thiazide that is safe in the renal failure is the metolazone. We need to remember this because while prescribing medications to CKD patient, we need to see to it if we should not prescribe CTD to him, or any furosemide. Indapamide is something which is has a decreased central systolic blood pressure, that is causing much of the hyponatremia, and we need to check for the electrolytes also for the patient. Calcium channel blockers, dihydropyridines, or we have the phenylalkylamines. Phenylalkylamine, diltiazem, verapamil, dihydropyridines causing reflex tachycardia, which includes your amlodipine, nifedipine, and every stuff. So this amlodipine is a long acting, nifedipine is a short acting, which is causing coronary steal syndrome. And coming to the fourth generation, these are very popular now. The fourth generation, we have L and T type of the calcium channel blockers, and these are very important as they do not cause reflex tachycardia, and there is reducing of the proteinuria also, very helpful. That is the clendipine. And there is also an L, N, and T type of the calcium channel blocker, which is a benidipine. So AC inhibitors or the ARBs, these are actually causing decrease in the systolic blood pressure. Okay, and this AC inhibitor is prescribed left and right very easily. It could be affordable and cost effective also. The patient could be affording these medications, right? But they cause cough and angioedema, so that has to be taken in the history. And what are the contraindications for AC inhibitors ARB? So we have we have many times read, if the patient has a bilateral renal artery stenosis, then it should not be prescribed. Again, it causes the renal failure, or it will cause more of the renal failure. Then we have pregnancy, only the labetalol drug has been approved, and in case of hereditary angiogenetic edema, because of its angioedema like features. Within 1 week of starting AC inhibitors or ARB, if the serum creat is increasing by more than equal to 30%, then we need to stop it because it is causing renal failure. Ramipril could be used 2.5, or we have perindopril. Okay. Some of the factors like losartan, which is causing uricosuric effect. So in case of a gouty patient, it would be used. Telmisartan has a long T half. Azilsartan has a high affinity to the receptor. Filmsartan is like 600 times more affinity to the AT1 receptor. Okay, so it has a longer duration of action, filmsartan. But these are all costlier drugs. But so the Telma and the Amlo, that is also prescribed by the which we get in the government centers. So these are very popular drugs. So that's for all. Thank you for watching. I hope you have enjoyed this video. We'll see you next time.